Good afternoon, everyone. Welcome to the Yale Sleep Medicine Seminar Series. My name is Ritika Thapa, and one of the faculties here at Yale. Just a few brief housekeeping announcements before I introduce today's speaker. Please take a moment to ensure that you're muted. And in order to receive the CME credit for attendance, please see the chat room for instructions. And if you have any questions or comments during the presentation, please use the chat room, or you can also unmute yourself at the end of the talk and ask the questions, and I will moderate the session. So without any further delay, I have the pleasure of introducing one of our stellar sleep fellows here at Yale, Dr. Matthew Ballenberger. He received his medical degree from St. George's University School of Medicine, West Indies. He then completed his internal medicine residency and pulmonary critical care fellowship from Jucker School of Medicine at Hofstra Northwell at Lenox Hill, New York, and is here at Yale finishing his sleep medicine fellowship. Brown University at Rhode Island was lucky enough to hire him, where he will be joining as a faculty after his sleep fellowship. Dr. Ballenberger is a very enthusiastic fellow, an excellent physician, and possesses deep interest in sleep-related hypoventilation patients and NIV, and he's also published on these topics. When he's not doing medicine, he likes outdoor activities and loves, to name a few, hiking, biking, kayaking, cross-country skiing, scuba diving, playing guitar. These are just to name a few. There was a bunch more outdoor activities which I had to leave out. So thank you so much for being with us, Matt. And without further delay, I would like to hand it over to you to share your slides on obesity hypoventilation syndrome, past, present, and future.
Thank you so much, Dr. Thapa. All right, so thank you everybody for joining me for my talk today. I chose this subject not only because I find it really interesting, but I think that a lot of times it gets OHS gets grouped in with the other hypoventilation syndromes, and I thought it was really worth taking a deep dive into it, and also especially taking a look at kind of what's in the pipeline for future treatment options and everything that may be working its way to all of us soon. So I have no disclosures, and like Dr. Thapa said, this information should be popping up in the chat for you for CME. So these are my objectives for today. I think in the name of time, I'm just going to get started, and we're going to briefly go into the history for OHS. So the earliest case reports of presumed OHS actually come from the late 1800s, and were the first really to describe these obese patients with excessive daytime somnolence who had resolution of their symptoms after they had weight loss. In the 1900s, this disorder was termed the Pickwickian syndrome, which was named after a character from a Charles Dickens Pickwick Papers, which was published in the 1830s. But a fun fact, the term is actually a misnomer, as it doesn't refer to Mr. Pickwick himself, but rather his friend Joe, who was described as being obese, sleepy, difficult to arouse with loud snoring and peripheral edema. But I guess Joe syndrome just didn't really have the same ring to it. So, but the term Pickwickian syndrome first appears in the medical literature in 1956 in a paper by Burwell and colleagues. And it was similar, describing patients with morbid obesity, plethora, edema, and hypersomnolence. So in the next few decades, there were numerous publications using the term Pickwickian syndrome, but this was very nonspecific and being used often to describe patients both with hypoventilation or hypersomnolence related to their sleep apnea, because there was really no formal definition as of yet. The first official differentiation came in the 1999 AASM guidelines. So this formally separated the two, with obstructive sleep apnea hypopnea syndrome being primarily caused by upper airway obstruction, and hypoventilation without obstruction causing sleep hypoventilation syndrome. So the first iteration was pretty nonspecific and kind of a grab bag for multiple hypoventilation, multiple causes of hypoventilation. But importantly, it did start to specify a BMI or it did not specify a BMI criteria, but it did mention that BMI greater than 35 was a predisposing factor. The first formal definition for OHS was published in 2005 by Alswin and Zwillick, which required obesity with a BMI greater than 30 and awake hypercapnia with a CO2 level greater than 45. They mentioned findings that might be seen on a diagnostic PSG, such as a OSA or nocturnal hypoventilation, but these weren't required for diagnosis. The current ASM diagnostic criteria is very similar, but further specifies that hypoventilation can be measured by multiple means, including end tidal or transcutaneous methods, and must not be due to other primary causes such as parenchymal lung disease, pulmonary vascular disease, chest wall abnormalities, medications, neurological disorders, etc. Current definitions across medical societies are mostly similar, but there are some notable differences. ATS requires sleep-disordered breathing as a diagnostic criteria, but doesn't further specify if this means obstruction or hypoventilation. And the ERS task force differentiated itself by proposing stages to further characterize the disease. So these stages range from 0 to 4 based on the degree of hypercapnia and associated comorbidities. Stage 0 is really just simple obstructive sleep apnea without any hypercapnia. Stage 1 has intermittent nocturnal hypercapnia with full recovery during sleep, but has no elevated serum bicarb. Stage 2 is where CO2 levels are higher in the morning than in the evening, but there is a permanent elevation in the serum bicarb. And stage 3 is going to have sustained hypercapnia during the day, which is consistent with the other societies' diagnostic criteria. And then stage 4 is the same as stage 3, but also says that the patient now has some associated comorbidities. So alternative severity categories have also been proposed based on a combination of blood gas levels, BMI, AHI, comorbidities. But these criteria lack validation and have not yet been widely adopted. So now moving on to prevalence, pathophys, and complications. So as we all know, the obesity epidemic in the US has really gotten significantly worse in recent decades. Current estimates place over 40% of all US adults as some degree of obese, which is up 10% since the turn of the century. And during the same time period, the prevalence of severe obesity has nearly doubled to just over 9%. And there's also significant racial disparity with non-Hispanic Black and Hispanic adults having higher obesity rates than non-Hispanic White or Asian adults. The overall prevalence of OHS is largely unknown, but it can be estimated based on the prevalence of OSA and OHS in these obese populations. So based on these calculations, we get an overall prevalence in the US that's somewhere around 1 in 110 or 0.9% of the overall population, which equates to about 3 million people with OHS in the US alone. And this estimate does not include 10% of OHS patients that do not have comorbid OSA. Prevalence data does vary significantly between studies due to variations in patient populations. But the most significant factor affecting the prevalence of OSA is weight gain.
Sorry, Matt. Sorry, Matt. Can everybody please mute themselves? Wendy, Debbie, maybe you could mute her.
Yeah, sure.
Okay.
So we're going to send the settings to the DME. They're going to send.
All right. So let's see, back to where it was. So one international review showed a prevalence of about 5 to 10% in patients with a BMI of 30 to 35, and about 20 to 30% in patients with severe obesity with a BMI greater than 40. And although the Asian populations have lower prevalence of obesity in the US, East Asian populations are known to develop OSA at a lower BMI than in non-Asian populations, and therefore may be disproportionately affected by OHS. This was supported by studies comparing the average BMI of OHS patients involved in the Japanese populations to studies that were looking at non-Asian populations. And they confirmed a much lower average BMI of around 32% or of around 32 in Japanese subjects versus 44 in the non-Asian subjects. So OHS is really caused by a combination of mechanisms that can be broken down broadly into 3 different categories. So the effects of obesity on the respiratory system, breathing abnormalities during sleep, and what I find really interesting, the alterations in the respiratory drive. So excess adipose tissue produces multiple effects on the respiratory system. Chest wall and lung compliance are decreased. There can be some resultant atelectasis, which can result in VQ match. And significant abdominal fat deposits can also impede diaphragmatic motion. So the cumulative effect of these results is a reduction in functional residual capacity, with even more pronounced reductions in vital capacity and expiratory reserve volume. Adipose tissue also directly impacts breathing during sleep by narrowing the airway and resulting in increased collapsibility. This commonly results in prolonged apneic events with inadequate recovery breaths, leading to CO2 retention. And this affects the majority of OHS patients, as only around 10% will have hypoventilation without any obstructive sleep apnea. Of the remaining 90% that have sleep apnea, 70% of these will have severe sleep apnea, and about 30% will have mild to moderate. So during these apneas and hypopneas, patients develop a CO2 load resulting from the difference between the metabolic CO2 production and the CO2 offloading during respiration. So patients with OSA without hypoventilation will have a proportionate elevated post-event ventilation that will restore eucapnia. While patients with obstructive sleep obstructive events with chronic CO2 retention will have a blunted ventilatory response that results in an acute on chronic CO2 retention during sleep. So with severe and frequent respiratory events, CO2 levels will acutely rise during sleep, resulting in renal retention of serum bicarb. And this will persist while you're awake and induce a CO2 retention to maintain a normal pH. And since the pH is then near normal, the kidneys will not aggressively secrete bicarb, which will further blunt the respiratory hypercapnic respiratory response during sleep, and kind of leads to this to these prolonged apneic events and just perpetuates this cycle. The final mechanism, central hypoventilation, is thought largely to be mediated by the hormone leptin. Leptin is produced by adipose tissue, and it decreases hunger while increasing metabolic rate and respiratory drive. Leptin deficient mice, obese mice, will hypoventilate when asleep and awake, and they have increased CO2 levels, decreased hypercapnic ventilatory sensitivity, and increased hypopneas in REM sleep. Leptin receptors are present in both the central and peripheral nervous system, with significant expression peripherally in the carotid bodies. Receptors in carotid body cell type 1s will increase carotid sinus nerve activity and augment the hypoxic ventilatory response and increase blood pressure. Centrally, leptin's receptors are present in multiple sites throughout the forebrain and the brainstem. A study published by Yale and colleagues in 2016 observed PSG changes from injecting leptin into the lateral and fourth ventricles in leptin-deficient mice. So they found that these injections induced an increase in minute ventilation in non-REM and REM non-flow limited breathing when injected into both areas, while injection into the lateral ventricle, but not the fourth ventricle, increased minute ventilation in flow limited breathing. So due to the rostral caudal flow of CSF, the authors concluded that leptin likely augments upper airway obstruction via sites in the forebrain, while sites in the medulla are responsible for ventilatory control. And although patients with OHS have increased levels of leptin due to their increased adipose tissue, there is impaired leptin penetration across the blood-brain barrier. So this creates a state that really mimics leptin deficiency, resulting in hypoventilation in sleep and awake, increased CO2 levels, decreased hypercapnic ventilatory sensitivity, and increased sleep disorder breathing. So this kind of helps differentiate the predominant pathophysiological mechanisms of the two primary OHS phenotypes. So the first example on the left is a PSG of someone with a primarily just blunted CO2 response without obstructive events, showing moderate worsening of CO2 during the night, particularly in REM sleep, where there were just a few of the only obstructive events noted. But the second is on the right is someone with comorbid upper airway obstruction that produces significantly worse nocturnal CO2 retention during the day or during the night, and an impaired return to baseline CO2 levels. So these patients typically have a significant burden of comorbid disease. A large study published in 2020 compared the comorbidity prevalence for OHS and OSA patients. found that OHS patients had higher rates of asthma, diabetes, hypertension, AFib, and psychiatric disorders compared to patients with OSA. Interestingly, though, there was no real significant difference in other cardiovascular comorbidities, such as hyperlipidemia, stroke, or ischemic heart disease. And another study in 2012 showed that nearly half of patients with OHS had pulmonary hypertension at the time of diagnosis. So how does this all translate to outcomes? Well, a case control study comparing OHS patients to obese controls had to double the number of physician visits per year and were 5 times more likely to be hospitalized in the 5 years prior to establishing their diagnosis. Another study compared OHS patients to obese controls and found that they were nearly twice as likely to be admitted to the ICU during hospitalization. They had higher rates of invasive mechanical ventilation and were much more likely to be discharged to a long-term care facility. The data for hospital readmission rates does vary, but one study comparing OHS to COPD patients requiring NIV during their hospitalization found similar rates of readmission, with about 50% being readmitted within 1 year. And another study showed up to 30% readmission rates at just 1 month for those who were not treated with PAP therapy on discharge. And as you would imagine, this results in pretty high healthcare costs, with a study in Denmark published in 2011 showing OHS patients generating over 7 times the annual cost of medical care and loss of labor combined compared to controls. And as you would imagine, this is probably significantly higher in the US. So with this significant disease burden and comorbidities, the population has pretty high overall mortality rates. One study following the newly diagnosed OHS patients at a hospital admission found an overall mortality rate of 30% at 3 years post-discharge. Another study with long-term follow-up compared mortality rates for OHS patients to OSA patients and found significantly higher mortality rates for OHS patients at the OHS patient population at 5 and 10 years, which persisted after adjusting for comorbidities, diabetes, and their ventilation therapy. So now getting into treatment. So the 2 broad categories for treatment for OHS involve facilitating weight loss and addressing sleep-disordered breathing and hypoventilation with PAP therapy. So the first key aspect involving weight loss. So two RCTs have been published looking into weight loss for OHS patients. So one compared the effect of intensive lifestyle intervention versus usual care for OHS patients. With this intervention consisting of professional recommendations for diet plans and exercises, with weekly phone calls to maintain their motivation. And the intervention group here had a larger weight loss, a bigger increase in the 6-minute walk test, an increase in health-related quality of life scores at 3 months. But the difference in weight loss at 12 months really didn't reach statistical significance between the 2 groups, though there was, unfortunately, almost a 50% dropout rate in this study that probably affected the outcome. The other randomized controlled trial compared OHS and severe OSA patients on PAP therapy to either laparoscopic gastric banding or intensive nutritional care. So this study found that the lap banding was much more efficacious at facilitating weight loss and ability to wean off PAP therapy at 1 year. But this difference was not maintained at 3 years, with the difference noted especially for PAP weaning wasn't sustained. And interestingly, was higher in the weight loss or the intensive nutritional care group. So numerous observational studies have documented benefit from weight loss brought on by bariatric surgery in the OHS population. These studies show significant and sustained weight loss out to 5 years, with improvements in blood gas levels and pulmonary artery systolic pressures. One study showed even complete resolution of OHS for all patients involved at up to 5 to 7 years of follow-up. So based on all of this, the ATS guidelines from 2019 recommend implementing interventions aiming to produce a 25 to 30% sustained weight loss, as they felt that this degree of weight loss is really what's required to have a significant impact on awake hypoventilation. There are no current guidelines for OHS patients regarding the newer classes of weight loss medications that have become available in recent years. But I'll talk about these just shortly because these may prove to be pretty promising for this population. So the second major essential component to treating this population is PAP therapy. And this has clear mortality benefits for patients. A large study published in ERJ in 2020 compared the effect of PAP therapy combining both CPAP and NIV on mortality for OHS versus obstructive sleep apnea patients. So this study found that OHS patients who abandoned PAP therapy had significantly higher mortality rates, approximately 60% survival rate at 5 years and just over 30% at 10 years, with those who continued to use PAP therapy. And those with OSA who had greater than 90% survival rates within the same time frame. Although the OSA group was found to have statistically significant PAP benefit as well, you can clearly see from these two charts here that the magnitude of effect was much larger than what was seen in the OSA group. So for patients without concomitant severe obstructive sleep apnea, non-invasive ventilation really is the treatment of choice, since there's thought to be less contribution to the disease process from upper airway obstruction. The largest study in this population was a parallel arm of the Pickwick trial and compared NIV therapy to lifestyle modification after 2 months, and then another study followed these patient group out to 5 years. So at 2 months, NIV was found to improve blood gas levels, serum bicarb levels, and had a modest improvement in sleepiness scores as well, but really wasn't found to have any significant change compared to controls in respiratory function. When they followed out to 5 years, the most pronounced continued effect was improvement in blood gas levels, but overall, it did not show a long-term improvement in other outcomes such as weight, respiratory function, and days hospitalized or mortality. But an ad hoc analysis was performed on the 5-year follow-up and separated the patient groups based on non-invasive ventilation adherence, and showed that the high adherence group had a longer time to either hospital admission, ED visits, or mortality compared to the low use group. For patients with comorbid severe OSA, CPAP may also be an option for treatment. And there are many more studies really analyzing PAP therapies for this group, with many of them focusing on the difference between CPAP and non-invasive ventilation therapies. So only one small randomized control trial has been conducted looking specifically at BiPAP or BPAP-S, which does not have a backup rate to CPAP. And this study excluded patients who had persistent hypoxia or CO2 retention on either of the PAP therapies. And outcomes for this study were pretty similar to another study that compared similarly BPAP with a backup rate, BPAP-ST, to CPAP in the same time frame. So both showed really no difference in outcomes and adherence, improvement in awake blood gases, or sleepiness scores. There were trends for BPAP-ST in reducing the awake CO2 and oxygen levels faster and to a slightly larger degree, but this really didn't reach statistical significance. One of the largest studies comparing non-invasive ventilation versus CPAP is the Pickwick project, which randomized OHS patients with severe obstructive sleep apnea to receiving treatment with non-invasive ventilation, CPAP, or lifestyle modification, and was subsequently followed up in the short term and then again in long term. Now, for non-invasive ventilation, the study utilized AVAPs, or the volume assured pressure support for non-invasive ventilation. And all patients in this group were set to tidal volumes between 5 to 6 cc's per kg, which is on the lower side for ideal body weight, and then underwent awake adjustments of EPAP and IPAP based on ABGs, as well as overnight titration study. CPAP patients also underwent a titration study and then were set to just fix CPAP pressures based on those results. So initial findings at 2 months showed more significant improvement in respiratory function parameters such as FEV1, FVC, and 6-minute walk test, as well as multiple echocardiographic findings, such as pulmonary artery systolic pressure and reduced LV hypertrophy. But this difference did not persist when followed out to 3 years. Similarly, at longer-term follow-up at 2 years and 5 years from 2 separate studies, the trend at 5 and 5.5 years favored NIV but didn't reach statistical significance. And there was also no change in long-term blood gas levels or hospitalizations, or no difference between the groups. So taking this just a step further, 2 studies evaluated outcomes for OHS patients and compared specifically BPAP-ST versus AVAPS. And both of these studies included patients with and without comorbid sleep apnea. So one used AVAPS with the fixed EPAP pressure, and the other used AVAPS with an automated EPAP, or AVAPS AE, which is technically considered a home mechanical ventilator. So the results of both of these studies showed a near identical reduction in awake PA CO2 levels. And interestingly, there was really no significant difference in the ventilatory parameters, at least for the AVAP study, on EPAP, leak, or patient-triggered breaths for either group. There was a trend towards higher compliance, interestingly, in the BPAP group, but this didn't reach statistical significance. So based on all this data, how can we really establish a diagnosis and get patients started on treatment? And what barriers will we really encounter along the way? And this will largely depend on if patients are going to present in inpatient versus the outpatient setting. So when evaluating a patient in the outpatient setting, the ATS 2019 guidelines recommends first screening patients based on pretest probability. So if patients are coming in and they're less symptomatic, their BMI is somewhere between 30 and 40, they have a moderate to low pretest probability. And so looking at a serum bicarb can be really useful for screening for chronic hypercapnic respiratory failure. They based a selection of 27 as the cutoff because this gave a sensitivity of about 86% and a specificity of about 77%. And so if the serum bicarb was found to be over 27, you still have to confirm the diagnosis with getting an ABG. But if patients are coming in and they're very symptomatic, very sleepy, and their BMI is over 40, they will have a high pretest probability, and you should really just go straight to the ABG to confirm the daytime hypercapnia to get the diagnosis. They did recommend the ABG, due to the ABG being required to establish awake hypoventilation. This really can present as a significant barrier, as these are not readily available at most blood labs and may be harder to obtain and more painful, which I know I've seen a few patients refuse these after they've been tortured with getting stuck multiple times. And just kind of going back here, they do further suggest for the ATS guidelines, daytime oxygen saturation should not be used as a screening tool, not because it's ineffective, but really just because there's a lack of validating evidence. So to fully establish the diagnosis of OHS, you have to rule out other causes of hypoventilation. And the most important test here is really to do a spirometry to rule out obstructive lung disease. And a lot of the other causes can really be reviewed after just reviewing patient data and also just clinically. So if you're unable to establish a diagnosis with an ABG, an alternative path to getting the patient established with PAP therapy is to undergo a polysomnogram, ideally with CO2 monitoring. But if the patient meets the criteria for nocturnal hypoventilation, and where they have more than 5 minutes total of saturation less than 88%, for at least 2 hours of the recording that's not associated with an AHI greater than 5, they will be qualifying for BiPAP or BPAP. If severe OSA is present, treatment with CPAP can be considered, but it's really ideal to do a titration study to show that this is there's going to be improvement in the nocturnal hypercapnia and hypoxia. If severe OSA is not present on the study, they should be started on BPAP, or if they're started on BPAP and they continue to meet this criteria for nocturnal hypoventilation should be switched over to BPAP-ST or AVAPs. But in either case, they really need follow-up to show improvement in symptoms, and ideally in blood gases as well, as the patients may need to be stepped up to AVAPs or a home mechanical ventilator if their current regimen is failing to treat their symptoms and their hypoventilation. But as you can imagine, this can pose significant barriers to care due to long wait times for outpatient visits and for polysomnograms, and especially because many labs have a limitation in the availability for CO2 monitoring during the polysomnogram studies. So the majority of OHS patients usually don't present as inpatient, though. They're coming in during an acute exacerbation into the inpatient setting. And they'll, unfortunately, at least especially with their first presentation, will often go misdiagnosed. So one retrospective study looked at OHS patients' first admission prior to their OHS diagnosis. And they found really a mix of admission diagnoses, with the majority being respiratory failure, then followed by heart failure and infection. So at 43% of these patients, when they came in, had also been previously misdiagnosed with having COPD. And then on discharge, really only 10% were diagnosed or were given a discharge diagnosis of OHS. This group had very high ICU admission and mortality rates, which part of which could have been due to this misdiagnosis and mismanagement. These patients were also, especially with their diagnosis of COPD, may have been exposed to really unnecessary medications such as steroid regimens in the past and been on inhalers that really weren't going to help them. So since these patients are obese and often have a lot of comorbidities, we should really have a low threshold for having OHS as the differential when they're presenting. We should really consider anybody with a BMI over 35 and a high serum bicarb at risk for OHS, which should prompt an ABG to confirm hypercapnic respiratory failure. Following this, if possible, an inpatient spirometry should be ordered to rule out obstruction just at the inpatient setting. Though I know this can be difficult to obtain because it's not always readily available. Likewise, getting an inpatient sleep test would be very ideal, but in many hospitals may not be available, which can really potentially also be a barrier to care in establishing this correct diagnosis early. Which is really important because correctly diagnosing the patients and getting them set up with PAP at discharge really has the potential for significant health benefits. A very large meta-analysis of 9 studies looked at about 1,100 OHS patients and the effect of prescribing empiric PAP at discharge after hospitalization for acute on chronic hypercapnic respiratory failure. So in total, about 90% of the patients were empirically started on PAP therapy, which resulted in a pretty significant reduction in mortality at 3 months that persisted at each point of follow-up out to 1 year. None of these studies were randomized trials, though, but this was a pretty pronounced and persistent effect, and so suggests that NAV at hospital discharge may really benefit the patients. If the diagnosis can be established, 2019 guidelines recommend discharging patients on PAP therapy with subsequent workup and titration study within 3 months. So current CMS requirements for bilevel PAP devices may make it difficult to set patient up with NIV. CMS criteria for BPAP is the same in the inpatient setting as it is the outpatient setting, and really falls under 2 categories. To get BPAP without a backup rate under the E0470 code, an awake blood gas on their prescribed FiO2 must demonstrate hypercapnia, and then spirometry must rule out obstruction. They must also then either have an ABG obtained during sleep or immediately after awakening, showing a difference in their PaCO2 level by 7 or more, or have a sleep study that's showing, again, the nocturnal hypoventilation as measured by their hypoxia for 88% or less, saturation of 88% or less on at least 2 hours of recording that's not caused by obstructive events. So then for BPAP with the backup rate or AVAPs, the same criteria must be met basically while the patient is being treated with the BPAP device without a backup rate. So as discussed before, this can really present a serious barrier to care, as although in the inpatient setting, ABGs are going to be maybe easier to get overall, they may still be difficult to obtain during sleep or immediately upon awakening, and maybe especially more difficult to obtain in severely obese patients. The ONMAP technical expert panel recommends discharging patients, if possible, on at least a BPAP ST, since this can make transition over to AVAPs very simple if they have failure of treatment with BPAP ST. So this barrier in difficulty in getting insurance coverage for BPAP S and ST is likely what's resulted in a very large growth in prescribing home mechanical ventilators, which is the AVAPS AE and IVAPS AE. Between 2009 and 2015, there was over 8 times increase in home mechanical ventilators being prescribed for conditions that could be possibly managed with a less expensive BPAP or BPAP ST. And largely this is thought to be due to home mechanical ventilators only requiring documenting life-saving medical necessity to get insurance coverage. So extending PAP coverage beyond 3 months is another significant barrier to care, as the patient's currently required to be reevaluated by the treating physician at 61 to 90 days of discharge and be compliant with the device greater than 4 hours per day for 21 of the 30 days. And this is really required to be met before they've been established care with a sleep physician. So something as simple as a mask leak or inappropriate empiric settings may significantly impact their ability to tolerate and use PAP overnight. Due to this this other barrier here, the ONMAP technical export panel recommended changing this requirement to allow follow-up at any time during the first 3-month period, and changing the compliance definition to really only requiring at least 2 hours per night for any 30 consecutive days during this 3-month period. And also recommended making patients be eligible for an additional 90-day extension period before coverage for NIV is discontinued, so that these problems can be addressed and troubleshooted. Post-discharge evaluation is largely similar to the outpatient management that we talked about before. So patients discharged on BPAP who are found to have severe OSA, they may be trialed on a step down to CPAP or APAP, though a titration study really should be undertaken to ensure this is still going to be efficacious at treating their nocturnal hypoventilation. Those who fail either BPAP ST or AVAPs with persistent hypercapnia or have continued symptoms after 3 months of compliant treatment should then be considered for transition to a home mechanical ventilator. So now going on to the future. There are already 2 therapies that have been known to impact hypoventilation for some time, which are medroxyprogesterone, a synthetic progesterone derivative, and the carbonic anhydrase inhibitor, acetazolamide. Medroxyprogesterone has been shown to improve CO2 levels and serum bicarb in postmenopausal women after 14 days of administration. Though it doesn't come without risks, because this drug is known to increase the risk for venous thromboembolism in a patient population that's really already at risk and predisposed to this from severe obesity and immobility. Acetazolamide, by comparison, is a weak diuretic and induces metabolic acidosis. So when OHS patients take this, it leads to a reduction in serum bicarb, which drives a metabolic acidosis, leading to a rise in minute ventilation, which should reduce CO2 levels. Studies administering acetazolamide to intubated OHS patients did show a reduction in serum bicarb levels, PaCO2 levels, and improved hypercapnic ventilatory response, as well as minute ventilation. But it really had no effect on the days on the mechanical ventilation. But for both of these medications, really larger long-term data is lacking. And so there's no current recommendations for the use of these drugs. So another potential target for treatment is leptin. So as discussed before, the leptin resistance contributes to weight gain and central hypoventilation, which is primarily mediated by changes to the blood-brain barrier that inhibit leptin penetration to the central receptors. So a potential vector for treatment is to administer intranasal leptin that can traverse the nasal mucosa, go to the olfactory nerve, or go through the olfactory nerve to deliver leptin to these central receptors. So this concept was explored by Berger and colleagues, who compared the effect of intranasal and intraperitoneal leptin, and then used a bovine serum albumin vehicle as a control, looking at metabolic and sleep parameters in leptin-resistant obese mice. And as was expected, the intraperitoneal leptin really had no effect on respiratory or metabolic parameters, as it did not cross the blood-brain barrier. But comparatively, just a single dose of intranasal leptin affected both sleep and then continued administration did affect metabolic parameters. In non-flow limited breathing, an increase was seen in mechanical or in minute ventilation in both REM and non-REM sleep. So this is thought to represent an improvement in hypoventilation during sleep that's not related to or not affected by obstructive events. And the prevalence and severity of flow-limited breathing was also decreased, particularly in REM sleep, which is correlating with a reduction in the number and severity of the obstructive events. So you can see this effect they demonstrated on the right here, where the especially during REM sleep, the degree and duration of these apneic and hypopneic events, as well as the degree of desaturation, was significantly reduced in the leptin group. And then chronic administration over 14 days also interestingly produced sustained decrease in food intake, as well as some modest weight loss. So based on this study, leptin may provide a potential target to address both aspects of OHS, targeting both a reduction in AHI, hypoventilation, and potentially mediating weight loss as well. But of course, this is only shown so far to work in rat models, and so we really do need long-term studies and those involving humans as well. So the recent rise of GLP-1 receptor agonist medication also offers a potential meaningful treatment for OHS patients by potentially helping to facilitate weight loss and potential decrease in AHI as well, and may circumvent the need for bariatric surgery. Unfortunately, there's no studies yet published examining or looking at the effect of GLP-1 receptor agonists specifically on patients with OHS, but there are multiple randomized control trials comparing the effect of liraglutide specifically on reducing AHI, which can apply to the 90% of OHS patients that have comorbid OSA. So one large study looking at patients with moderate to severe OSA showed that liraglutide reduced AHI about twice as much as placebo. Other studies comparing liraglutide alone versus CPAP alone versus the two in combination showed all groups had a reduction in AHI compared to baseline, but the liraglutide alone was pretty insufficient in reducing your AHI to target levels. So this really suggests it's still using these medications may long-term benefit patients, but it's definitely important to continue PAP therapy if starting a patient on liraglutide, since it is pretty ineffective by itself as monotherapy in addressing obstructive sleep apnea. But there are currently multiple ongoing trials to take a look at this further. So the most recent data for this group of medications came out just last week with the results of the SURMOUNT OSA trial. This was a phase 3 clinical trial evaluating the effect of tirzepatide versus placebo on AHI reduction. It consisted of 2 trials, both involving patients with moderate to severe OSA over a 52-week period. The 2 parallel arms of the study consisted of patients who were not on PAP, that was study 1, and study 2 on patients who were on PAP therapy. So at 52 weeks, both studies showed really impressive results with a significant reduction in AHI by nearly 30 an hour, or by reducing 50% overall. And it also showed with a nearly 20% median sustained reduction in weight. And they also did note that this was a pretty impressive weight reduction since this patient population was primarily male, and they've been known to really have kind of a blunted response to this medication group. So although the study really didn't look directly at OHS patients, it may likely provide a benefit for patients with OHS who have comorbid OSA in facilitating this reduction in AHI. And it really may benefit both groups with and without comorbid OSA, since this medication produced really significant and sustained weight loss. And this 20% was pretty close to the recommended target of the 25%. So we may soon be able to avoid the need for bariatric surgery altogether. But we do have to take this data with the study with a grain of salt. It's not yet been presented, or it's only yet been presented in a press release. It hasn't yet been peer reviewed, but we are fortunate enough, though, to have our own thorough assessment provided by our very own Dr. Yagi to the New York Times, as you can see here. So another recent phase 2 trial was published for the combination therapy of atomoxetine and oxybutynin as oral medications targeting reduction in AHI. So the mechanism here is the noradrenergic effect of atomoxetine, increasing genioglossus muscle activity in non-REM sleep, and the antimuscarinic effect of oxybutynin affecting it during REM sleep, and also adding a slight sedating effect as well. So this study showed a pretty significant reduction in AHI with successful reduction to less than 10 in nearly half of the patients, without affecting total sleep times, sleep latency, or really engendering significant side effects. And although the effect on the respiratory events was pretty significant, there was pretty little effect on patient symptoms, though this study overall had a fairly unexpected, rather robust placebo effect. So that may kind of have diluted the effect between the two groups. And currently, there are many ongoing trials looking at multiple combinations of oral medications for the treatment of obstructive sleep apnea specifically, and then one phase 2 trial for an undisclosed medication specifically looking at treating patients with OHS. So with all these medications kind of coming down the pipeline, if even a few of these get approved, the next few years may be very interesting for all of us, because this could pretty significantly impact our field and management, since we may be the ones responsible for administering these and monitoring their effects and everything. So thank you, everybody. Special thanks to Dr. Tapa for all your help on this, and open to any questions if anybody has any.
Thank you, Matt. That was really a very excellent presentation, a very thorough and deep dive in this really challenging and fascinating topic. There's Dr. Yagi, who's also said, Matt, that talk was awesome. Great talk. I have a question, Matt. So, you know, these patients are really challenging, right? When they're mild they get underdiagnosed, misdiagnosed. When they're severe, they come to the MICU and they have chronic respiratory failure, they get intubated. And the trials that have shown that, CPAP's better, this better, we still can't give them CPAP. And there are multiple hoops that you have to go through to get a BiPAP. So your patient goes on BiPAP, comes to you in the clinic. What are the things could you talk about the things that you would assess in terms of their BiPAP settings or their oxygenation follow-up, their ventilation follow-up? What are the things that you would look at or suggest based on your deep dive?
Yeah, I think it's looking at really a lot of things, especially if they're being compliant with therapy. You can really try to compare if there's any effect symptomatically. Are they sleeping better throughout the night? Are they less sleepy throughout the day? Getting some updated labs are also going to be pretty helpful. Like we were talking about before, it can be very difficult to get an ABG, and so I know there are some studies that have shown that VBGs may be pretty significantly correlated, and so maybe the combination of getting VBG if ABG is unavailable, repeating a BMP, and seeing if there's really any reduction in serum bicarb levels. And then also, if depending on if a sleep study was able to be done in the interim, seeing if the patient, if they have obstructive sleep apnea, comorbid obstructive sleep apnea, is the download data showing that really are we adequately treating respiratory events? Do we need to go up on the EPAP to help with this setting? And then if we're really not hitting like our goal, they may still be hypoxic during the day. They may still be retaining CO2. Definitely considering doing a titration study and trying to expedite it if that's at all possible. and specifically seeing if there really needs to be either a backup rate if they can qualify for a backup rate and benefit from that, or just increasing the delta between the IPAP, EPAP to see if we can really help augment the hypoventilation more during sleep.
Yeah, great. Yeah. Pulse oximetry, I think the bicarb levels that you said, the downloads, the tidal volume rate, because I don't think we still have definite things besides the download and all these, accessory tools to just assess. So more in the pipeline, and hopefully, the on-map recommendations gets approved and, it doesn't become this challenging. Yeah.
Yeah, definitely.
Thank you. There's next question from Stuart Min. Do bicarb levels taken right after waking up vary from those taken later in the day after being awake all day?
I didn't see anything that was specifically looking at this data-wise. I would say it's probably unlikely to vary fairly significantly, since the renal response is pretty blunted and can take a while to really affect things. But it may also depend on the disease state and like how far advanced the disease is. Like if we're going by those kind of the ERJ stages where someone may be more like on the milder side, lower stages, where you might be seeing pretty significant PCO2 level differences between nighttime and daytime still. There could be more of a difference potentially, but if people who are kind of more late stage where they're just constantly hypercapnic, you may not see much of a difference.
Yeah, so there might be, little, especially because awake, you're trying to assess what you're trying to do is just assess the nocturnal sleep-related hypoventilation. So what you're trying to target is you're trying to get that CO2 level based on the nocturnal hypoventilation. So that's why you have to target the early morning, soon awakening, just so you're sort of mimicking the nocturnal. And the other alternative is getting a nocturnal hypoxic, proving that they're hypoxemic at night too. So if you can't prove that, which is always difficult, the other alternative is to prove that they're hypoxemic as well at night. I don't have any other questions. If anyone has any other question, please feel free to unmute yourself and ask the question to Dr. Ballenberger. In the meanwhile, I don't know if you got to look into that. when you presented the data on the liraglutide combination and CPAP alone, the reduction was more with just CPAP. Did they give a reason why that was?
I'm not.
It's
I don't
not a
know if they
big
had gone through that
difference.
specifically.
Okay,
And I'm not sure if this was just a kind of like due to management of the CPAP settings, or
right. Okay.
because they ideally they're both pretty close to being at goal, 5 or less
Right.
or so. So
Yeah, it's just a
yeah,
tiny difference, but
yeah. So it would have been interesting, I think, if they had then gone ahead and seen, with done maybe a crossover study or something, or seen if they can, like,
right,
what the effect would be with removing the CPAP therapy.
right.
Yeah.
But medications are coming soon, hopefully.
Yeah. I think it'll
All
be
right.
really interesting to see too, because all of these different medications are kind of targeting different things, and you may have the tirzepatide affecting things more longer term, and in the interim may be able to start some patients on these other kind of new other medications that may help reduce at least AHI as
Right.
well. So we may be looking really at kind of combination regimens to manage things in the short term, and then getting people to where they need to be in the long term.
Right. Different target. Yep. All right. I don't see any questions, but that was an excellent presentation, Matt. Really
Thank you so
proud of
much.
you. And thank you so much, everyone. Have a great day, and thank you so much for joining us. Bye-bye.